Hello, my name is Ava Firth. I'm sorry I can't be with you in person today, but I hope that you'll find this presentation useful and engaging nevertheless. I'm a specialist in emergency and critical care. I've been practicing in the UK for some years now, and today's topic is oral rehydration therapy. And we'll speak about it specifically as it applies to our patients, some critically ill and some not so ill. So let's get started with a little bit of background. You'll find that this presentation is not your average PowerPoint. It's a bit more of a mind map, really. First, we're going to talk about how we got to where we are today and run through some background of fluid therapy. Second, then we'll look at a little bit of physiology and the activity of oral rehydration therapy and how it actually works. Then we'll have to take a small pause to break the video up into two parts so that it's manageable. And starting in part two, then we'll pick up with clinical conditions, several kinds of examples and commonly found patients that can benefit from oral rehydration therapy. Last but not least, we'll talk about how you can implement ORT in your practice and go on and have some success with your patients. So let's get started. I'd like to say that in the beginning life was good, the air was pure, the water was clean, and it would have been good if it could stay like that, but things got crowded. As civilization became more developed, cities developed, people got crowded together with suboptimal sanitation, very often no running water, and those conditions led to waves of plagues throughout the centuries: dysentery, cholera, bubonic plague, and influenza. And many thousands, hundreds of thousands, millions of people have died due to these diseases. Physicians, however, healers throughout the centuries have tried to manage these problems in the best way that they knew how. And one of my favorite medical heroes is a man named Moses Maimonides. And he was a physician in the Middle East in the 1100s. And he's still known in medical history for writing some of the first intelligent medical textbooks on the treatment and diagnosis of respiratory disease. And you might imagine that his advice included get a lot of fresh air and drink clean water and take a bath every so often and eat fresh food. But one of the things that makes him near and dear to my heart was that he advocated the use of chicken soup as a nutritional broth for an ill patient. And that makes him a pretty smart man, in my opinion. Unfortunately, nothing much changed for the 600 years after Moses because it was the Dark Ages. And by the time that the cholera epidemic of 1832 rolled around, raging through Europe into Britain and then on to the Americas, the treatments of choice for cholera were still bloodletting, uh, literally draining blood from patients in an effort to relieve the whatever it was that was supposed to be running through their veins, and alternatively, or sometimes in combination with making the vomit. And many patients were given calomel as an emetic in an effort, again, to remove the horrible thing that must be raging their bodies. As you might imagine, the success rate on this was fairly poor. And so, in 1832, there was a canny Irishman, a doctor named O'Shaughnessy. He's practicing up in northern England and Scotland, and he actually took some of the blood that had been let out of a patient with cholera and analyzed it. He had a bit of a laboratory streak in him, and he managed to measure the fact that the blood was deficient in water and deficient in what he called carbonate of soda. And that translates to what we see in our diarrhea patients today with dehydration and a metabolic acidosis. So he was spot on with his analysis. Another physician, Dr. Latta, who was a Scotsman practicing in Leith, took up that information and realized that, well, maybe if he could replace that fluid and those salts, that his patients would get better. And so he concocted the recipe, and I love reading this recipe. It was 3 drams of muriate of soda and 2 scruples of subcarbonate of soda in 6 pints of water. And the only problem with that is that the water wasn't sterile. It was still a hypotonic solution. As you can see here, it has an osmolality of about 100, which is about a third of what we would expect to use nowadays in these kinds of patients. But nevertheless, it was a good start. And so, for the beginnings of fluid therapy, we have to give credit to O'Shaughnessy and Latta. And things moved on from there a little bit, and people did realize that isotonic fluids were better and more effective, and that then became normal saline as we still use it today. 154 milliequivalents of sodium and 154 milliequivalents of chloride and nothing else. But it saved many patients. 50 years later, another physiologist named Sidney Ringer, a British physician, was experimenting upon the activity of cardiac muscle cells and realized that they would only contract if he supplemented saline with a little bit of calcium and a little bit of potassium. And that became Ringer's solution as we still know it today. Another 50 years went by, and an American pediatrician named Alex Hartman was trying to treat his patients, primarily children, with diabetic ketoacidosis. And he realized that he needed a source of bicarbonate, so he added lactate to the Ringer's solution, and that became lactated Ringer's solution, or as we know it in the UK, Hartman's solution. And that still forms the mainstay of IV therapy today. So by the mid-1900s, medical practice in Britain was ticking along quite nicely. Intravenous fluids were being used routinely on many patients, particularly after World War II. And this is a picture of the original hospital at University College in London. But then, in 1971, another epidemic struck. This time not in Britain, but in India and Pakistan, who were having a war at that time. And hundreds of thousands of refugees were holed up in camps in an effort to escape from the fighting. And as you can imagine, with poor sanitation, crowded conditions, poor water, it wasn't long until a cholera epidemic broke out, and people literally were dying like flies. The few hospital facilities that were available were completely overwhelmed. The medical personnel were completely overwhelmed. So some of the local physicians decided to try simple oral fluids, and they created this recipe of a little bit of salt, a little bit of sugar, and a little bit of citric acid. And they taught the parents of the children how to spoon it into the mouth, spoon by spoon, hour by hour, patiently, over a few days, and the results were stunning. the mortality rate in the camps dropped from 40% to 3%. And let me tell you, the world sat up and took notice. The World Health Organization subsequently adopted this formula, and it is still affectionately known as WHO juice. And it forms the basis of most of the oral rehydration supplements that we have on the market today. A little bit of salt, a little bit of sugar, and a little bit of flavoring. So what did we learn out of that experience with the epidemic? We learned, first of all, that patients can survive cholera without IV fluids, which is a major development. O'Shaughnessy and Latta probably could have done us all a service, but it's interesting to realize that it took another 600 years for us to solve the problem of cholera. Secondly, and probably more importantly, we realized that you can put something down the gastrointestinal tract of a patient who has nasty GI disease. And this was counter to the current thinking at that time. Everyone thought that you couldn't use the gastrointestinal tract because it would have been completely dysfunctional. But we learned that if you use simple solutions, then the GI tract can absorb these nutrients. They'll be absorbed through the wall of the enterocytes and taken up into the capillary circulation, where then they can go on and be part of the systemic circulation and contribute to the necessary bodily processes. So, take-home message out of all this is that unhappy gastrointestinal tracts don't tolerate solid food. That's no surprise. But isotonic fluids are useful. They do need to be isotonic because the transport mechanisms across the enterocyte wall are sodium dependent to some degree, and so that's why just giving plain water won't work. We need to give simple sugars and amino acids, not much fat particularly, just simple sugars. And by doing that, we can nourish the enterocytes, and after that, then we can go on and to some degree nourish the rest of the body. So we've come full circle from centuries ago, through the Dark Ages, through the cholera epidemic, and through the development of intravenous fluids, and we've come right back full circle to the use of oral rehydration therapy in very ill patients. And Oralade is one of the products that I really like to use. I've been using it for about 5 years now, and one of the great things is that it's tasty and it's well accepted by the patients, which is, I'd have to say, different than some of the other products that are on the market. It's based upon chicken broth. It's a chicken liver hydrolysate that provides the amino acids and the flavoring, and so we're building on a lot of history here with Oralade to use a chicken soup kind of product. It's not just legend or anecdotes, however, that say chicken soup is good. In 2000, a group of physicians in America actually sat down and decided, okay, we're going to test chicken soup and see if it really can do anything. And they lined it up on a standard laboratory assay that is used to measure neutrophil activity, and they used their grandma's chicken soup recipe, and they published the recipe in the journal article. And they did find that chicken soup inhibited neutrophil activity and was considered to have a mild anti-inflammatory effect. So that gladdens my heart and puts a little bit of science behind something that I've always suspected was true. You'll be pleased to know that ramen noodles were actually worse than water in their effect upon neutrophils, and Campbell's hearty chicken soup was right behind Grandma's in terms of effectiveness. Now, it's not just gastrointestinal physicians anymore who are using oral rehydration therapy. It's starting to broaden out into other fields of human medicine. And this study was published just last December in a group of burn patients. Now, a small group, mind you, it's only a handful, but these patients were started on IV fluids as usual. But burn patients lose huge volumes of IV fluids, of fluids because of all their losses. These patients had between 20 and 40% of their body's surface area burned. And within a couple days of starting ORT, the investigators found that the need for IV fluids had decreased by 48%, so basically halved the requirement for IV fluids. And that led to support the conclusion that ORT can be a very useful adjunct to intravenous fluid therapy in critically ill patients. By using ORT, we can decrease the requirement for IV fluids, we'll improve the gastrointestinal barrier function, will reduce the chances of peripheral edema and pulmonary edema, and all of those are useful things. Let's have a look at the physiology of how ORT actually works. It's not difficult. First of all, let's look at the sugars. The enterocytes can only absorb from the gastrointestinal lumen out here, they can only absorb monosaccharides, either glucose, galactose, or fructose. Anything more than that has to be broken down by other digestive enzymes in the small intestine. But through those dedicated transporter molecules, these simple sugars can be absorbed straight into the enterocyte, passed out the other side through another transporter molecule, and go on into the capillary circulation and be used for energy by the rest of the body. Amino acids are organized on much the same principle. There are separate transporter molecules that are designed to take up either single amino acids or maybe up to chains of 3 or 4 amino acids. Those small chains are broken down by intracellular peptidase enzymes within the enterocyte, and at the end of the process, single amino acids are absorbed into the capillary circulation and again taken up into the systemic circulation. So we need to have simple sugars, small chain amino acids, in order for enterocytes to do the least amount of work and deliver the most effective source of nutrients. Now we're going to need to pause for just a minute to break this video up into 2 sections, so that it will actually be manageable through the wonders of technology.